hopefully give you a few ideas in your practice and in your world, how patients perceive communication and what it means for them when they're in between appointments or in between being in the hospital or a procedure. So that's my basic goal today. One of the things that I feel strongly about is that since I've been on both sides of the examining table, both as a patient and as a clinician, I've learned over the years that when I, as a clinician, former clinician, actually would describe a condition or the limitations, then I was not aware that the patient possibly is thinking something else. So that's just a basic concept that I want to convey to you today and answer any questions that you might have. So what are the key points here that I want to share with you? One is that patients will create stories. We all do that naturally when events happen in our lives. We want to make stories. What did I eat that didn't help my stomach? Was I driving too fast? Did I have too many glasses of wines? Patients will create stories about their health and what caused a condition based on the information they receive. But that is filtered and reflected by their age, their gender, their background, their culture, and their beliefs about their body. These stories that they carry around with them in between appointments, in between taking their medicine, in between going to the gym, as you heard the prior speaker talk about, can actually impact their mental and physical well-being. And so I want to wrap that around the concept of shared decision-making and just point out a few tips about how to go about that so that the patient's unique values, preferences, and desires are put into the conversation and are well understood. So a little bit about myself. I am an HCM patient that has had symptoms since birth. I don't mind sharing with you, I'm 66 years old. I founded a few years ago a patient advocacy organization and a consulting business. So I work with patient groups, patients individually, pharmaceutical companies, academic centers, researchers, medical device industry, pretty much anyone in the healthcare segment to help them identify and coach patients so they can tell their stories in meaningful ways. And I really emphasize meaningful and useful ways. Oftentimes I'm asked to tell my story, but without a lot of guidance as to what that means. And so my role is sort of a third party, is to come in and really translate what the medical system is saying, what a patient is hearing, and what a patient does with that information on the days that they're, again, in between appointments and living their lives. As you know, hypertrophic cardiomyopathy is a lifetime condition. So management of that is not to a point where you're going to be cured, but it's really a disease management condition. I'm a physician assistant by training, expert. I'm also an attorney, a lawyer by training, and I've worked in Washington most, if not all, of my career. So one point about story that is really important, and it's a simple concept to keep in mind, is that we know from social psychology is that individuals, all of us, will remember information more quickly and accurately when it's told in the form of stories. Now, this isn't really surprising. We think about narrative medicine, or when a patient comes into the emergency room, tell me what has happened. So individuals and patients are accustomed to the stories. Oftentimes they can be frustrated in how they represent their symptoms in the story they tell. But the point to make here is that patients not only hear information, may maybe get caught up in the data and the terms and the drugs, but they begin telling themselves a story. And I want to just share very briefly with you why this concept to me is so very important and how it played out in my life. When I was first officially diagnosed with hypertrophic cardiomyopathy, it had a completely other term. It was called idiopathic hypertrophic subaortic stenosis, IHSS. I was in graduate school. I had just moved to Washington, D.C. I had a very traumatic experience on the subway, on the metro, where I was on the floor of the metro. And I thought I had a heart attack. I couldn't breathe. I was very diaphoretic. I was just anxious. I felt like a horse was kicking the inside of my chest. People were trying to help me and I was pushing them away. I literally thought I was going to die. This is over half of my lifetime ago. And the next week, after being transferred to the emergency room at George Washington University Hospital, and then seeing a cardiologist the next week, the very first thing he said to me, the very first thing, I still remember it today, is you will have a shortened life expectancy. You will have a shortened life expectancy. I'll never forget it. I was in such a high state of shock, having grown up in a family where several men had actually died of sudden cardiac death. And here I am coming to Washington, D.C., hoping to make something of my life and to benefit from all the education that I had in the cardiac world, working for the Surgeon General, working in organ transplants, and being told I would have a shortened life expectancy. And I want to circle back to that in a minute about how, again, this power of stories stick. Data and details are oftentimes fuzzy, but stories stick. And that story always stuck with me. I was advised not to have children. I was warned of the mental health and emotional consequences of living with the condition, and that pretty much it was a fatal condition, that they were doing research on animals at the National Institutes of Health. But that story followed me my entire life. So when the doctor said X, when the doctor said you will have a shortened life expectancy, without quantifying that or giving me any idea of what that meant, the story I told myself is, I'm going to die young. I'm going to die soon. Now, I want to fast forward many years later, many years later, several decades later, when institutes of excellence began to build in the United States for the treatment of HCM or hypertrophic cardiomyopathy, I chose to go to Mayo Clinic in Rochester, Minnesota. And the first thing that was said to me was, just because you have hypertrophic cardiomyopathy doesn't mean anything bad is going to happen to you. The same diagnosis in the same condition by two very well-educated, very prominent clinicians were sort of like bookends throughout my life. And I remember those stories, and they influenced how I felt about my own longevity. They impacted the choices I made about education, my money, to never have children. I became isolated. I struggled with this information in between those two bookends. But just to wrap this story up and to move on a minute, I also came back to Washington, D.C. and returned to see this cardiologist after I had not seen him for over 8 years. And when he was examining me, he looked at me and he said, I don't think anything has changed. Your EKG, your echocardiogram, you look just like you did 8 years ago when I last saw you. And I mustered the courage to say to him, but you never said I could have a normal life. And he was puzzled by that. He was like, what do you mean? Of course, you can have a normal life. And I said, but that's not what I heard. And that's not the story that got planted in my head many years ago. So looking back on that whole experience, we became very close, provider-patient, better communicating and understanding as the forms of communication improved. And I recognized that I was telling myself the worst case scenario, that my actual story had actually had a huge impact on my sense of well-being and health throughout the years. So with that in mind, I just want to introduce the concept of shared decision-making. One of the values we know is it helps overcome health literacy challenges. We live in a multicultural world. People can be on vacation, they can be a holiday and a travel. The divorce rate, at least in the United States, is very high. Families are integrating, families that grew up in with different translations, different language barriers. So shared decision-making, where there's back and forth of a dialogue, rather than the patient simply hearing the information, is really much a value of shared decision-making. We can demonstrate compassion and personal interest. Patients no longer feel like that they're less than, or that somehow they are not smart, or they don't know enough. When you ask what their values and their preferences are, you're demonstrating compassion for them. It also, at the end of the day, helps the patient be a willing partner in their healthcare. Once they're able to articulate and better understand in their words what is being told to them and what is needed of them, whether it's exercise, as we heard earlier, diet changes, a repeat exam, a different clinician's evaluation. Once they can articulate and have a two-way street dialogue with a willing partner, they are more likely to keep to that regimen. I just want to note that in 2020, at the end of the year, in the midst of the pandemic, the American Heart Association and the American College of Cardiology, which are our most authoritative bodies other than the government, these are non-government associations in the United States, came out with the guidelines for the diagnosis and treatment of patients with hypertrophic cardiomyopathy. They came and summarized a 125-page document with over 20 authors cited, and they pared it down to 10 tips or 10 important things to remember in the management of hypertrophic cardiomyopathy. The number one recommendation was shared decision-making, that it is a dialogue between patients and their care team, full disclosure of all testing and treatment, that you discuss the risk and benefit of these options, and you engage the patient to understand what are their goals, and particularly relevant to the treatment of HCM. HCM is not a linearly progressed disease. Patients have good days and bad days. Their pressure gradients can vary. Mine has been as low as 9 a few weeks ago, now that I'm on medication that was recently approved by FDA, all the way up to 89 millimeters at rest the year my mother and her mother died, and that was 25 years ago. And it's been everything in between. So understanding the individual patient's goals and preferences is really the key to shared decision-making. So how do we go about it? Here's a brief mnemonic. There's plenty on the internet. I'm sure many of you heard of this concept. So I'm just going to be very brief. With the concept of share, you want to seek your patient's participation. Let them know and take the time to sit down and explain what is underway. You want to help your patient explore and compare treatment options. I'll never forget recently when a clinician at the University of Maryland said to me, "How long are you willing to tolerate living in atrial fibrillation?" That was a personal question after having been treated for 3 years. How long are you willing at this age in your life, with the work that you do and the international travel that you do? How long are you willing to live with this condition? You want to assess their values and preferences. For someone like myself who did not have children, has a genetic mutation that I'm aware of, then my value of passing this on, or my concerns of passing this on to my children, simply doesn't exist. For many HCM patients, that is their number one most important preference and value. Should they test their children, what will be the impact in their lives? Can you reach a decision point that is unique to that patient, and how you evaluate that patient's decision? So you want to guide, but remember at all times that the questions are there. A few simple questions, such as, what does this mean for your life right now? How can I help you accept this information or deal with this information right now? Are very important questions that are part of shared decision-making. I want to highlight very briefly before I wrap up and take any questions you might have. One of the most confusing things for patients, and clinicians do it automatically, because they look at a whole lot of data in the chart, in the electronic health records, and they've got numbers in their heads, and they've gone through training, and they talk quickly in numbers and estimates. But patients have a hard time. I don't care how well they're educated, language barriers, family barriers, dynamics. Patients have a hard time instantly hearing news, which again starts their storytelling process, and absorbing the numbers they hear. So here's just a few tips, and I wanted to just highlight again how this played out in my life. Elaborate providing estimated numbers. So when a clinician said to me, "You will have a shortened life expectancy," my response was, well, what does that mean? What does that mean? My parents were in their 50s at the time. I thought they were ancient. I thought they were really, really old. I thought living to 50 would have been the pinnacle, the outcome of a well-lived life. And all I got was, we don't know. Now, statistically, I understand that all the clinical research this doctor had available to him might have shown a decrease in longevity or mortality. However, it wasn't conveyed to me that way. And so my mind began telling myself stories. A couple of other bullet points on here. Give the absolute risk instead of a relative risk. So again, if there was a way that it could have been explained to me so that there's an absolute risk, maybe a 1% chance or 2%, it would have been better. And make my numbers meaningful. Limit them, maybe use everyday words. I remember also I was told, reminding me of the prior presenter, I was told, don't push yourself. I had no idea what that meant. And I was physically active as a tennis player, and worked and did aerobics and yoga and all kinds of things. And there was little to no information on how to do that. So those are just a few of the things, and I'll conclude here and just thanks those who organized this to provide me this opportunity to share a few things. To just recap, is to remember is that it's common for all of us to remember stories and to begin telling ourselves stories. When we hear numbers, and the medical system can be so overwhelming, and patients will begin to tell themselves stories in their head. It may be based, in my case, upon finding and learning of many individuals in my family on my mother's side who had sudden cardiac death and the impact it had on her life. So I grew up as a small child hearing that. Culturally, it may be something different for someone else. Maybe it might be that you are at an age where you're struggling to get through school, or you're wondering to get married, or what is your insurance status? Very important here in the United States. So these stories we tell ourselves can often have a huge impact on our physical and well-being. And then finally, please understand and explore, if not already so, the value and importance of the management of HCM by utilizing shared decision-making. It is a lifelong condition, and those discussions should occur every time a patient presents. With that, I will wrap up and conclude, and happy to answer any questions anyone might have. I'll turn this screen back over to you.
Doctor, that was an excellent presentation. You spoke about the importance of communication and compassion in life through your own personal life experience. You spoke through your heart. Wonderful presentation. I would like to know any questions